changed this, so I don't know that they'll be available. I mean, some of it will be the same, some of it will be different. If you want.
Do you want people taking pictures?
Oh, not in the least. Thank you. Well, hello. So I want you to know that it's about 2 in the morning where I come from. So if my narcolepsy kicks in, you'll forgive me. My name is Tena Moyer. I'm a psychiatrist and I'm a director of liaison psychiatry at Sierra Tucson. Now, Sierra Tucson is a psychiatric facility. For those who are unfamiliar with us, we treat substance abuse, trauma. We do some eating disorders. We treat, military trauma as well, mood disorders, pain program. But the real question is why does a psychiatric hospital need a liaison psychiatrist? Because the position of liaison psychiatry is traditionally something in a hospital where, the patient becomes like hallucinating or combative after surgery, and the surgeons go into a panic and they call the psychiatrist, and the psychiatrist comes in, interviews the patients, and gives the surgeons a Valium, and everything's fine after that. But which you usually need 2 Valiums with a surgeon, but anytime that there's like humanity involved. But anyway, at Sierra Tucson, my role there is to really take some of the more complicated behavioral cases or the more complex psychiatric cases and try and sort of make sense of it. And in order to do that, we have to step outside the traditional bounds of psychiatry. But in the same way, a therapist has to step outside of the traditional type of therapy they practice. So really what I want to talk about today is a different way of thinking about patients. So, I have to talk into the mic. 6 blind men come across an elephant and they say, we've never seen an elephant. As a matter of fact, we've never seen anything, but we've certainly never seen an elephant. What is an elephant like? And so they decided via Braille to figure out what an elephant was like. The first one grabbed the tail and said, it's like a rope. The next one grabbed I don't know what it grabbed. It grabbed something other, the trunk, and said it's a snake. The next one grabbed a limb and said it's like a tree. And so on. An ear is like a fan. A wall, the side of the elephant is like a wall. The tusk is like a spear. And they continued to argue about that, debating who was right and who was wrong, until suddenly somebody came along who was sighted and asked them what the conflagration was about. And they said, well, we're having a disagreement about what an elephant is like. And that man said, an elephant is exactly like an elephant. So it was at that point the blind men realized they were blind. Why is this important? Because as mental health professionals, we tend to be shunted into very specific tracks. For example, how often do you find a psychoanalyst who is also a licensed substance abuse counselor? How often in this day and age do you find a psychiatrist who can actually do insight-oriented psychodynamic therapy or somatic therapies, whatever you're looking at? We tend to stay in our lanes, and that means we think in our lanes. It doesn't mean we're thinking about the patient. We're thinking about the way we understand patients to be. So in dual diagnosis, which was, I think that's a concept that's about 20 years old, the idea was, well, look, you've got substance abuse and a mood disorder, and they certainly affect one another, so we should treat them together. Because you can't treat them sequentially. They depend on one another both to get better and to get sicker. So this whole concept of dual diagnosis was developed, of addiction and of psychiatry. And they looked at how mood disorders and anxiety disorders affect substance use, as well as how substance use manifests as symptoms of mood disorders and so on. So these are obviously important pieces to examine. I'm not going to linger on them today because most of us have some familiarity, with dual diagnosis. But in addiction, I think there's important things to think about. Especially what I start looking at is drugs of choice. I think that this actually tells us a lot about patients, and I'm going to get to that later. So I want to sort of put a highlight on that one. In terms of psychiatric disorders, I want to look at, in particular, two things. Obviously, the medical is important. If there's a medical problem, it doesn't matter what medication I throw at the patient. We need to treat the medical problem. But I want to, in particular, look at behavior and signs and symptoms, because oftentimes what looks like a psychiatric symptom is actually representative of another process. So what I'm trying to do, or the way I think about patients, is I call it a holographic vision. What does that patient look like in 3 dimensions? And how do those fit together as a 3-dimensional puzzle? Whoops. So these are the basic areas I've identified. I'm sure somebody like a lot smarter than me could come up with more, but I'm not that nuanced. But I want to look at how these things blend together to actually make our patients much more complicated and much more human than we recognize them when we are stuck with the textbook, the DSM criteria. So let's start with the biological. And I want to take this from the beginning because I think we need to understand what's happening in the brain. We're born with 100 billion neurons. We don't get any more. Einstein may have had 200 billion, but most of us are lucky if we make it to 100 billion. What's important is that while there are no nerve cells that are generated, with an exception which we'll come to later, that what happens is you have an increase in neuronal connections. These are synapses. That is basically that the cells, the nerve cells, grow out and send out little arms and legs, and they meet one another and they connect to one another. So what we get is synapse production. And when, for example, if you decide you're going to learn to play piano, you're going to start out with, if you're like me, very few connections around that. But as you practice over time, you're going to create more and more connections. You're not going to create nerve cells. You're going to create more and more connections so that those connections become automatic ultimately. This allows the brain to respond to the environment. And what happens as we grow is that we have pruning, which is that the synapses or those regions that are not needed start cutting back on their synaptic connections. So I want you to look at this. A newborn is born, remember, 100 billion nerve cells here. But they're born with very few synapses, okay? And over time, there's a month. Look at how much more there is. 9 months. Look at 2 years. And then look at an adult. An adult has fewer synapses than a 2-year-old has. Because what's happened is pruning has come in. And those unnecessary connections have now been severed, or they've not been emphasized. But the brain is actually at its most synaptic density from about 2 to 5-ish, somewhere in that age. So these are profound events. Whatever the brain is learning from 2 to 5 is going to impact the brain of the adult. I want to especially look at this period from newborn to 2 years because of what's going on in that child's brain. We're going to get to that too, so keep this in mind. Look at the increased density, eventually recognizing that we're going to have a decrease. This is also another piece. This is myelination. So myelin is basically a fatty insulating layer around neurons that helps them fire faster. And if we look, it's white in these pictures. So here's a 10-year-old. Look at all that white stuff. Look at that newborn. There's very little, isn't there? So again, the emphasis is what's going on in that 10 years. What is the brain learning or not learning? Mirror neurons are very important. It's a relatively new discovery. But mirror neurons are actually in the motor neuron cortex. It's wherever there's motor activity happening. And what they do basically is they see what somebody else is doing and they're mimicking that activity. So if I wave my hand like this, my brain, the part of my brain that manages, my right arm is very active. It's firing away. But what's happening in your brains is the part of your brain that manages your right arm is also firing away. It's very active, okay? What this allows us to do is to notice what somebody else is doing and imitate it or imagine what the meaning of that gesture is. So what's important here is if I raise my hand to wave goodbye and you've never been beaten by anybody, it's goodbye. But if this is your borderline patient who has been beaten by somebody and you raise your hand, maybe that means to that patient that you're going to beat them. And that's what you have to deal with. That's what's important, because that's what the patient is responding to in terms of the relationship you have with the patient. There's some thoughts that they're present at birth because at about, I want to say, pretty early within the first year, we start seeing infants mimicking facial expressions. Why is that important? Because facial expressions are universal. It does not matter the culture you come from. In fact, we could look at a chimpanzee and we could know if it was feeling fear, we could know if it was feeling disgust, we could know if it was feeling love or excitement. So these are universal. So the baby is learning a lot from what your face looks like, not just what you're doing. There we go, let's do the right thing. So taking that, I want to look at memory briefly. Memory, there's two types of memory. The first is implicit memory, which is a non-conscious memory process. The second is explicit. It is a conscious process. Let me take a look at my next slide here. Okay, so implicit memory, it is probably present at birth. There's some good, so I always used to make fun of the idea of doing, rebirthing therapy or something. I'm pretty old-fashioned. I'm like, oh, you got to be kidding me. And then I learned about what's going on in the brain at birth, which is we are capable of implicit memory, which also means because of when the brain develops, that we are going to have some cognizance of when we're in utero, of what's going on around us, okay? So it contains somatic and emotional memory. We remember the way things feel. We may not be able to make sense of it, but we remember it. So if I'm 2, because at 2 I still don't have explicit memory, if I'm 2 and a German Shepherd snaps at me or growls at me, I'm never going to remember that. But all of a sudden I'm 22 and a German Shepherd snarls or snaps at me and I go into a panic. I have no memory to relate that event to, and so I feel crazy. So when we think about, let's imagine a child that grows up in a highly chaotic, violent home. They're going to hear it, they're going to see it, but they're not going to remember it. And we're seeing them 40 years later, and they have absolutely no capacity to tolerate chaos or to tolerate raised voices, but they don't understand why it is. These neural circuits in implicit memory have to they fire based on, again, an emotional or an environmental stimulus. They do not fire because you can consciously acquire them, or you can consciously order them to fire. So remember, just looking at that piece, these are related to the limbic system because the limbic system is an unconscious system. This is your fear system. It's actually your emotional system, but the single most important emotion we have is in fact fear, because if we're not afraid of something that can eat us, we're going to get eaten. So we need to go automatically to a place of fear, and whether that means we respond to it by fight or flight is a different issue, but we need to get there without thinking about it. So this is nonverbal and often preverbal. This is occurring while those synapses are forming in that early developmental stage. Now, explicit memory. Remember what I said about there are no new nerve cells. This is not true with explicit memory because the hippocampus is sort of the seat of that type of memory. We remember stories, we remember semantics, we remember specific things because the hippocampus can do that. Because within the hippocampus there are stem cells, and every time a new stimulus comes along that says, do this, remember that, that hippocampus is going to make a new nerve cell. So in that sense, we can add those into those synaptic connections that we're making by adding in new nerve cells, right? So I now know how to make a triad on a piano instead of just look at the keys and feel completely intimidated. This is the kind of memory that you can verbalize. It's about knowledge. It starts to come online, and importantly, I want you to see that at 24 months. It's not really consolidated until about 5 years old. So what does that tell us? It tells us that the first 2 years of a kid's life, they don't remember anything except the way things felt, right? And it tells us that we might start getting a little bit of memory and somewhere between 2 and 5 years old, but it's really not on board until we're 5. And when do we really start school? Oh, well, I don't know about the British system, but in the US, it's kindergarten, which is 5 years old, because that's when children can start retaining more information. So this is just a quickie to look at. I will apologize beforehand. This is usually a longer presentation than I just found out I only have an hour, so we're going to truncate some things. But I do think this is important. I want you to see that the auditory system is on board around 18 to 20 weeks. That is in gestational age, not in after you're born age, neonatal age. So remember, that baby can hear what's going on in its environment even when it's in utero. It can't make sense of what's going on, but it can listen to it. And this is important because fluid conducts sound better than air does. So by the time the baby comes down the chute, the baby knows the mother's voice. The voice is imprinted, right? But there's also something else, which is the baby can hear stress in the mother's voice. The baby can hear fear. The baby can hear positive experiences, playing music, whatever it is. The baby can hear mother's voice. The baby can hear the environment. So if it's a violent environment, you bet the baby can hear it. The other thing to realize in utero is that if you have a stressed mother, she is pumping out all the stress hormones, okay? And those are circulating and affecting the way the baby's brains develop as well. So I want you to look at that piece. I want you to see that the hippocampus, there it is on board at 2. The consolidation of the language areas, without going into it, there is basically a receptive and expressive parts of the language system, but they're not connected to each other until about this age, about 15 months, okay? Now notice also, at about the same time, we're starting to get pruning in the prefrontal cortex. So I'm going to give you a patient example here. This is a 22-year-old woman who came to me with a long history of opiate addiction, heroin, specifically IV heroin. She wasn't using oral. She was just using IV. And she had been to many treatment centers, and she always relapsed. And the thing is, it was ego dystonic. She hated being a heroin addict. She hated everything that had to do with it. She didn't even like the way she felt. But she couldn't help. She was addicted to IV heroin. Well, we can imagine the brain, what's going on in terms of the addiction, the addictive brain. But let's look at what else was going on. This was a girl who was adopted. Her birth mother was a drug-addicted young woman, and there were twins. So think of it, just take a moment. She's in utero with a twin, and they're squished in that space. And you can be sure that they can hear each other's heartbeat and they can feel each other's skin because their sensory system, their tactile system is on board later in the pregnancy. So the sister spent a week in the NICU. My patient spent a month in the NICU. She was the more unstable of the two. The sister presented with anorexia, alcoholism, borderline, and I'm sure a lot of other kinds of drugs. But my patient herself, she had a history of eating disorder which had been resolved. She certainly had anxiety pretty severely and some depression. But it was this heroin addiction that kept her coming back for more. She had multiple treatments. She was very motivated. She'd basically been on every pharmacological intervention we can do for opiate use. And the important thing I also want you to see, I just shouldn't be allowed to use technology. It's not a parody picture. She had an adopted younger brother who had no issues whatsoever. They were adopted in the hospital. I mean, the parents were there for the delivery. And the father did come every day to visit, and the mother came when she could. She was home with the other newborn. But again, in the United States, this was a point when we did not understand the importance of being held as a newborn. And so he could look at her, but he couldn't touch her because we just didn't know any better then. So, okay. One day, I was working with this patient. I'm thinking, she had good enough parents. there's a connection to her parents and her family. But she has this profound anxiety, which is, again, it comes from nowhere. She had some very interesting signs, like she was acutely sensitive to sound. Sound could be a real activating experience for her. But the truth is other than that, she really didn't have many trauma symptoms, and in terms of classic symptoms. But I'm looking at her, I'm thinking, I'm missing something. I'm missing something really important. So one day, this is 18 months, 2 years into the work, she said to me, she had just had another relapse. She said, it's not really the heroin that I need to get. She goes, I really get relief when I see the needle go into my arm. What is that telling us? Think of an infant in NICU. Who touches her? The nurses. What do they touch her for? They're rattling her lines. So she goes from being squished next to her twin and feeling her mother and her twin all around her and hearing their heartbeats and being completely connected to being in an incubator, or whatever we call them in this day and age. Okay, so automatically the sensory experience has radically changed. But in addition to that, there was something brilliant I was going to say that I can't think of because one of my neurons just died. Anyway, the point of it being that what she was doing is she was reenacting the very little physical human contact she had. Okay? And, that's what I was going to say, is the awareness, the hyper-awareness of sound. Think of an infant. You're in the NICU, and all you're really hearing is whatever, respirators and machinery. But when that nurse comes in, and that nurse is rattling around somewhere in that room, you might be touched, you might be held. And so she was acutely aware of sound. Now, I'm going to say that pretty much after we got through this, she started getting better. She never relapsed. She eventually quit therapy. I would like to say that it's because I'm a brilliant therapist, but the truth is it's because she got pregnant, and through her infant, she could heal her own trauma. I mean, I think I helped a little bit, but the truth is it was the infant that healed her. It was not any work that I did with her. So looking at attachment, because that's really what we're talking about with this young woman, looking at that attachment as a piece. I want to look at what's going on, and let's go back to this picture. What's going on here? Well, for those of you who've had children, what you recognize is while we're starting to get a little bit of language and we're starting to get a lot of motor activity in here, we're really not doing that much else. Infants aren't apparently doing a lot of something. And yet, during this period is when we have the greatest synaptic connections occurring. So what's occurring? What is the baby learning? The baby is learning about attachment. The baby is learning what relationships are like, what it's like to live in the world. This is the most important learning experience of our entire lives because it becomes the platform that the rest of our adult personality is built upon. So I'm not going to run through this too much, but I just want you to see a couple things. At birth, infants will make every sound known to man in every single language. But by the time they're a couple of months or 4 months old, they're just using the sounds of their native language, right? And then as we go on, they start responding to sounds. They start moving, looking towards the sound. They're able to create sound better themselves. So when you think of all those synapses growing, this is what we're doing. We're learning language and we're learning attachment. In the infant is something called the neuroception system. And this is basically parts of the brain that are reading the emotional tenor and the safety of the environment. So how do we determine if somebody is safe or not safe? We look at their gestures, we listen to their voice, we look at their facial expressions, and we see how they move, right? And that tells us, is this person safe or not? So that's what the neuroception system is basically teaching the baby about safe from unsafe and what it feels like to have safe people taking care of you versus not. So now what happens is this. Let's look at a threat. That's the growling German Shepherd, for example. That triggers the sympathetic nervous system. And that in turn creates that fight-flight reaction. Now, an infant can't really do either of those things, but nonetheless, this is what our brain is trained to do. It's got like 500 million years of vertebrate evolution underneath that system right there, maybe 400 million. But what happens when that's triggered is I want you to look at this. We look at the norepinephrine. So that's basically adrenaline, the adrenaline rush, and we'll talk about it, but I want you to, in particular here to look at dopamine, because dopamine causes seeking behaviors. And when we're threatened, what do we need? We need safety and protection. And this is a mammalian characteristic. You don't see this in lizards. If lizards get scared, they don't all get together and go, wow, that was tough, man, the guy ate Joe. They're just like going, ooh, you're smaller than me, I can eat you. Because for a reptile and for the limbic system, anything bigger than you is a threat. Anything bigger than you can eat you. Because when that baby lizard is hatched, this big lizard comes along and eats it, and it happens to be the baby's mother. But the mother doesn't know it, and the baby doesn't know it. So anything bigger than me can eat it. But with mammals, we can't do that, can we? With mammals, we have to be in connection because we are utterly dependent on these really large things to have benign intent and to take care of us because we need to breastfeed, right? I mean, long before there was formula, there were boobs. So that's what we evolved to look forward to in life, right? So this is what happens is we need to learn to come together when we're under threat. We need one another for protection. And if you think about 4 million years ago with a bunch of little Australopithecines running around in the Serengeti, and there's a little troop of them, 10 or so, and they're like, whoops, let's break the mic. They're, maybe like 3 feet high or something like that. They're pretty small. They're not very fast. They're certainly not strong. But a lion comes along, and it's like going, ooh, dinner. I have a buffet here of, 10 Australopithecines I can eat. Except that the first Australopithecine that notices the lion starts to hoot, starts to vocalize, right? And those hoots, the other members of that troop recognize as being identified, there's a threat around. So they get together, and they all get together, and they pick up sticks, and they beat the ground, and they throw rocks at the lion. And the lion says, I'm going to go eat a gazelle. This is really a pain in the ass, right? And so then afterwards, all those poor little Australopithecines with their activated sympathetic nervous system, and they're so scared, and they're so worried. And oh my God, we almost got eaten, but we chased it away, and thank God. And what happens? That dopamine, which is it is not a pleasure. I want you to be clear, because in substance abuse, we tend to oversimplify and say it's the pleasure neurotransmitter. It is not the pleasure neurotransmitter. Pleasure is a motivator, and dopamine will cause that cause that motivation to happen. But dopamine is really more about seeking behaviors. And so now we've oh my God, we've had that threat, and we're going to all get together, and we're going to chase away the lion, and afterwards the lion's gone, and we're going to feel so much better, and we're going to pat each other on the back, and we're going to pick bugs out of each other's fur, and if we're bonobos, we're going to masturbate each other, and we're going to just all feel so much better. Okay, it's gone, my heart rate is down, my respiratory rate's down, I feel better, right? That's the social engagement system, and that is motivated or mediated with oxytocin. If this is the fight and flight response, this is what I call friends and family, because that's really what we're doing, okay? That oxytocin is released, and what happens is we get together, and everybody feels safe, and everybody feels together. So let's take a look at oxytocin. They call it the love hormone. It's actually the attachment hormone. It's the connection hormone. So what it does is it's released in childbirth, and it causes uterine contractions. And that's why the mommy spends 10 hours pushing out this baby in horrible pain, and she's peeing and pooping and bleeding and screaming, and she hates her husband, and there it is. And then the baby is born, and they put the baby in her arms, and she goes, you're the most beautiful thing in the world. So I also happen to think there's probably some ability to erase memory with but anyway, so now the baby's brain is flooded with oxytocin, the mommy's brain is flooded, and everybody's together. And even the dad's in there, and his brain is flooded with oxytocin. But mother and baby are sharing the same oxytocin, right? Because mother's making it, uterine contractions, and then it circulates into the infant's blood supply. It's released at lactation. It causes milk letdown. If the nipple is stimulated, it causes milk letdown. And that's why at 3 in the morning when the baby cries, the mother wakes up and instead of throwing the baby out the window, which would be the rational thing to do, she in fact breastfeeds the baby and sits there and resents her husband because he doesn't have to get up there and lactate. And he's still asleep. It's released at orgasm, okay? It's also synergistic, especially with estrogens, less so with testosterone, but it's synergistic with both of those. Because what happens at orgasm? Well, in theory, you're going to make a baby, right? And it's in the best interest of a mammalian baby to have more adults around to protect it. So basically what you're doing is you're cementing that relationship between this male and this female. And this is like the honeymoon phase, what we think of in relationships, love at first sight. It's just basically your sniffer is recognizing a good genetic match. It really is. It's about a good genetic match. And then your oxytocin gets pumped out because your genetic match wants to make it with that genetic match, and they'll make better genetic babies. And that's what we're doing. So it's basically the basis of, the love at first sight or that early rush in a relationship. It's just oxytocin central. And don't try and talk your teenagers out of having a relationship with that horrible boy because it's not going to work. It's also actually been seen to be beneficial as a side issue, just in wound healing and in feeding and satiation. And why is that important? Because look at our eating disorder patients. What do they have a problem with? It's actually not food. It's not about food. It's about feeding, because feeding is about attachment. And feeding is about safety and relationships. And that's what the struggle is. And if we make it about food, we are missing the point. We are not going to cure our eating disorder patients by making them eat the right foods. They have to live. We have to make them eat healthy enough. But we're not going to cure them because we got them to eat. We're going to cure them because they found out that they can have relationships that are safe and comforting and soothing. And that can be transferred we can think of in a way that the food as being a transitional object. There's a lot of ambivalence around it. Eating disorders are so pernicious and so difficult to treat simply because they're happening. The groundwork for them is being laid during that period of implicit memory development. It's about attachment. And then you get born into the family culture and you're lost. So let's look at, we've got our little oxytocin rush going. We're looking what's happening in the parasympathetic nervous system, which is called the ventral vagal, and I'm going to talk about that. And basically, it's reversing everything that's going on with the sympathetic nervous system. It's calming the whole body down. I'm just going to look for slides. Okay. This is kind of in the wrong place, but that's okay. We'll just go right into polyvagal. I don't know to what degree polyvagal theory is discussed or utilized in Great Britain. So I don't know if this is completely new or little or a lot. But basically it's based on an evolutionary basis of how the mammalian nervous system works, which is there are two vagal nerves. The vagal nerve is cranial nerve number 10, and it basically innervates your entire GI system. It innervates your pacemaker in your heart, so heart rate. It innervates the nerve that comes to your diaphragm. So all of this is vagal. The vagal nerve is basically keeping your body running, okay? Your blood vessels, your gastrointestinal tract, because it's all happening in the gastrointestinal tract anyway. There's two components of it. The first is the dorsal vagal, which is evolutionarily a very old component. The ventral vagal is a mammalian, a mammalian invention. And importantly, that ventral vagal is myelinated, which means that it's firing at a much faster rate. They support different survival strategies. So if we look at the dorsal vagal, it's primitive. It occurs in all tetrapods. It's unmyelinated, so it's a slow system. It basically innervates your gut. It's most of it. It also innervates your heart, but its basic effect on the heart is actually a very slow heart rate. Like you wouldn't be able to get out of bed in the morning, okay? It's very slow. It slows metabolism in a stressful environment because in a stressful environment we need to preserve our resources, right? So if it's low oxygen, if it's low food availability, we need to slow that body down so that the body doesn't make as many demands, and therefore the lack of food or the lack of oxygen doesn't harm internal organs. That survival strategy that it supports is the freeze strategy. And that's based upon, one, that lowered metabolic needs, and two, and more importantly, it's based on the fact that predators see movement. They don't see form. Many, at least mammalian predators, are in fact colorblind. They see movement. And so if I freeze, it doesn't see me, and therefore it won't eat me. Because scavengers look for smell, but predators are looking for movement. The sympathetic nervous system, as we discussed, is that the sympathetic nervous system, the primary neurotransmitter released is, it's actually a neurotransmitter and a hormone, but it's released into the system. It increases heart rate. It increases the pace, or it activates the heart. So when you get a rapid heart rate, it's because you have more sympathetic activity. It is it's connected into the amygdala and the limbic system, which means that it's really directly responsive to fear experiences, emotional experiences, but again, fear is the paramount one. And its survival strategy is fight and flight, fight or flight. And then, so we're looking here at the limbic system, and just want to look at that. It encodes memory, emotional memory, and it interprets it. Why does that matter? Because when the predator walks into the scene, I don't have time to think about it. I'm going to be eaten before I think about it. So I need to have a reflexive emotional response that says, get the hell out of here. This is dangerous. It also interprets motor activity. So like I said, I may wave at you, but to a borderline, I'm going to hit her. She's interpreting the intent of my action, okay? It's not connected to a conscious system. So remember, when your patients are activated, they don't even know why they're activated, okay? Now, a conscious system can manage, therefore CBT and DBT are helpful, but it's not connected itself to a conscious system. It responds to basic sensory input, and it has some prefrontal cortex input. The ventral vagal, like I said, is a mammalian adaptation. Another thing that mammals invented was the diaphragm. Other tetrapods do not have a diaphragm. That is uniquely mammalian, which means that our mammalian vagal nerve, our myelinated ventral vagal nerve, is going to control our breathing, right? It's going to come from the central nervous system, and it's going to tell us how fast we need to be breathing, okay? It innervates organs and structures above the diaphragm, and the important piece of this, I'm trying to think what I have it, which slide I have it on, I'll go to it next. It basically brings our bodies back to homeostasis, lowered heart rate, lowered respiratory rate. We're going back to eating, because if you're being chased by a predator, you really should be digesting dinner, or you're going to be dinner. So one thing that, you've ever, listen to our language. It scared the shit out of me. It scared the piss out of me. Because we need to get rid of that stuff in our gastrointestinal system. It's taking up needed calories and needed energy and needed blood, which we need to shunt to the skin and to the muscles. So that's basically called, when you're in a parasympathetic ventral vagal state, it's basically called the feed and breed, or the rest and digest. It receives input from the entire sensory system. It's directly connected to these important: speech, vocalizing, swallowing, chewing, facial expressions. Why does that matter? Because we're mammals, and if I'm sucking on a breast, I can't breathe at the same time I'm sucking, because I might inhale milk, right? And then I'm going to get pneumonia and I'm going to die. So I need to stop breathing and start sucking. Okay, likewise, when I'm done sucking, I need to start breathing. So basically what's happening in this ventral vagal system is it's allowing mammals to be mammals, because it's controlling behavior in such a way that we can consciously, as adults at least, go, okay, I need to drink the water rather than inhale it. So it manages all of these aspects of it. And I also want I want you to see that it manages facial expressions. So what does this mean? It means actually that ventral vagal system, which is our mammalian system, our friends and family system, is directly connected to the muscles of our face. And therefore, we can read intention on the face because we recognize it. Our little mirror neurons go, ooh, I get that. I'll tell you, I was talking to my stepdaughter, who's now 18, a couple months ago, and I don't remember even what I was going on and on about, but I started to notice that my face felt weird. And I like going, what's going on? And I suddenly realized, oh my God, I've become my mother. I'm talking to her the way my mother talked to me. And my face was picking up what she was feeling like, and it was like, okay, I need to shut up now. So this is real. It's survival strategy, like I said. I want you to think of it as friends and family, because that's what it's about. And as mammals, that's what it's about. So back to our little diagram, this is how we get here. We go from the sympathetic activation. Well, we actually start at the ventral vagal. We're grazing, eating our little grubs out on the Serengeti. There's a lion, threat comes in, it activates the sympathetic nervous system. Everybody gets hysterical, but they all get together, they throw rocks at the lion goes away, and it's like, oh, everything's better again. And this is the cycle. This is a healthy cycle. So just briefly, I don't want to go over this too much, but the norepinephrine, again, it's increased heart rate. It's everything you need to either run away or fight, which means the blood needs to go to the muscles. It also means it needs to go to the skin, because when those muscles are working, the temperature in the body goes up, and we need to cool that body down, or we're going to boil the brain. So it's going to go to skin and muscles, and it's going to move away from the gastrointestinal tract. It increases blood glucose, because you need to have blood glucose in order to take action. So basically, the norepinephrine, think of it as everything that gets you ready to fight and flight physiologically. Dopamine, like I said, it's really a seeking neurotransmitter. It's about motivation, desire. Now, interesting, notice that it's actually the neurotransmitter in a lot of the motor system. It's involved with arousal and pleasure, learning, approach. Why does that matter? It matters because two reasons. One is I need to find safety, and I know what safety feels like, and so when I'm stressed, that dopamine is getting me to go get soothing, to feel better. I'm pleasure seeking, right? In this case, I'm relief seeking, okay? So that's what's happening here, and it's creating the activation and the motor activity to go get my needs met, whatever those needs are in the moment. Finally, I want you to look at cortisol. Cortisols are basically, when we think about inflammation, we're thinking about cortisol, because it's active in a lot of like body inflammatory processes, especially things like fibromyalgia, things like that. So I'm oversimplifying here, but cortisols are also released, and we'll get back to that. And notice how it affects memory. It increases emotional memory in the short term, but it basically gets in the way of a lot of memory retrieval and memory implantation, or memory encoding as well. But it increases that emotional memory. Why? Because we need to know that we're scared. We need to know what to be scared of. So let's come back to our little picture here at our autonomic survival strategies. And we see we have our threat, and it's activating our sympathetic nervous system. And our sympathetic nervous system is going, okay, I need to get some help, and I'm going to go run over there and seek some help from my little friends and family. But here's the problem. What happens when it's drunk mommy or it's abusive daddy? So I run to abusive daddy and I say, the doggy growled at me, and little daddy goes, whack, stop being such a baby. Uh-oh, I went from predator to predator, didn't I? So now I'm, as a child, really stuck because there's no place else to go. So what's happened now is we have the parent as the predator who activates that, comes back over here and activates even further that sympathetic nervous system, because there's no safety in the world. The world is a dangerous place. Activating that central nervous system, we're amplifying that sympathetic activity, and the kid has no place to go. So it's just going into fight, flight, which is anger, fear. Now, are you going to get mad at your abusive daddy and go, Daddy, when you hit me, it makes me feel sad, angry, and scared? No, you're not going to do that because he's just going to hit you again. So you're really stuck. You cannot challenge scary predators because they will eat you. So you really are kind of stuck over here. But the main thing is you are in this constant state of activation with no place to go. This is that sympathetic protective system. This is that ventral vagal protective system. That leaves you to go to the oldest part of the survival nervous system, which is that dorsal vagal system. And that's going to shut my body down. That's going to shut my brain down. It's going to shut my body down. And it's a hypoarousal state, and we're going to touch on that again a little more. So what I want to take a look at is when we're talking about dual diagnosis, we can talk about drugs and alcohol, but I think we need to talk about this, in fact, which is, people who have happy enough childhoods and safe enough parental relationships, I'm not saying they don't experiment with drugs in high school and college, and I'm not saying they never become addicted. But really, this is not who shows up in our practices. It's the people who had whatever happened to them, right? So basically, when we look at that dual diagnosis piece, we need to recognize that there's this whole dynamic going on. That's part of it. For example, we can understand, if we look at the anxiety, the flight response is an anxiety response, and we can look at anxiety disorders, and we can, from an evolutionary standpoint, recognize the value. Because the most anxious person in the herd, or in the troop, is going to notice the predator first and send up the alarm, and we as a group are going to be safer because we have a neurotic, anxious guy in the group, right? So that works for the rest of us who don't have anxiety. It sucks for the guy who does. But it works, okay? And so anxiety, we can imagine it would be a heritable disorder, or a heritable disorder. There would be value in that gene. Depression is a different story. Bipolar is a different story, but we can see that here. But what happens here is you have this chronic state of sympathetic activation, right? You're going to see the anxiety disorders. Think of it, when you start to seeing anxiety that is not medication responsive, start thinking about what's going on here. Same thing when we look at fight, anger disorders. So intermittent explosive disorder, oppositional defiant, conduct disorder, antisocial, any number. Look at these sort of aggressive kinds of behaviors really represent that activated nervous system that's saying fight or flight. And if you think about it, what do we call a little girl who gets angry? She's a bitch. She's a cunt. We have some pretty nasty words, right? Because little girls don't get mad. Who gets most anxiety disorders? It's women. More common in women, because women are not allowed to be angry. That's a forbidden feeling in most European cultures. What do little boys get? Where do we see most of the aggressive disorders? It's in little boys, isn't it? Because what do we call a little boy that gets scared? You're a pussy. You're a mama's boy. So basically, we have this cultural process that's shunting kids in one direction or the other. Okay, I'm almost out of time, so I'm gonna run through this really quickly. But I want you to see that, to recognize that these disorders can represent a state of active sympathetic activation. I also want you to see that the next option is to go to that freeze state. And we can think of depression and dissociation and the numbing and paralysis of trauma as a freeze state. And this is when we have these patients that are not responding to medication. I mean, we kind of know how depression works. We really have some pretty good meds for it. But when they're not responding, it's because we're missing this piece of it. We're not recognizing what the psychodynamic aspects and the developmental aspects of the disorder are. So thinking of these as a responsive state for two reasons. One is, if you're in a chronic state of sympathetic activation, you've got high cortisol levels, and high cortisol levels cause depression. Okay? So that's one of the reasons. The other thing is, nobody can stay up here all the time. You got to go somewhere, and so you go into a state of collapse. Alternatively, because I'm running out of time, I'm going to improvise a little. I want you to look at this and think, okay, if I'm a really pissed off guy, what do I need to amplify my anger? because if I'm angry, I can protect myself from the predator, right? So what am I going to do? I'm going to use cocaine. I'm going to use stimulants. I'm going to use alcohol because alcohol basically disinhibits my brain and I become, what's that t-shirt? Instant asshole, just add alcohol. So, that's what I'm going to be looking at is these activating meds or activating drugs of choice. They are meds. When we're looking at the flight response, we're going, somebody who has to stay away from anger, right? So I need sedating drugs. I need opiates. I need cannabis, I need benzos, and so on. I'm not being, this is not black and white across the board, but I think that it's very important to look at drugs of choice. Because and this later in the presentation, which we won't get to, when I had a 35-year-old guy who came in with like devastating anxiety. He was at Sierra Tucson, and oh my God, and he was so afraid his wife was going to leave him because, well, he'd been bringing prostitutes home and sleeping with them, which I think any wife would be a little disturbed about. But in the meantime, he's also a commodities broker in Chicago, and he's also using massive amounts of cocaine. And so the question was, well, we're trying to treat him and the therapy, and he's just and he was like so pathetic and, cooperative and appropriate, and we just don't know how to help him with his anxiety. And I'm thinking, anxious people are not commodities brokers. Anxious people do not use cocaine. They use opiates. So what are we dealing with here? We're dealing, in that case, with an anger response that's being acted out sexually because think of sex and the way we express anger in our culture, at least in the United States. Fuck you. Go fuck yourself. He's a dick. She's a cunt. Our language for anger is very sexual because anger is sort of the ultimate fuck you. So there's a whole story to this guy that we can look at as what happened developmentally. Unfortunately, we won't have time to get to it. But I want you to remember that the behaviors, not just substance use, but behaviors have meaning that tells us a lot about our patient. We could have pursued his anxiety with medications and therapy forever, but we were going to miss the point because the point was he was really a pissed off guy, probably related to stuff when he was about 3 to 5 years old. But if we don't capture that anger and shine a light on it and illuminate it, then it doesn't matter how much anxiety work we do with him, he's still going to act out because what he is angry. And he needs a way to manage his anger in a healthier way. I'm going to just run through a couple of things here. Well, one thing I want to say, we think of capital T trauma in terms of, major events, a sexual assault, military experience, a first responder, a motor vehicle accident, a major illness. That's pretty clear. That is usually an explicit memory experience. Now, if they have the defense mechanism, the ego defense of dissociation, they may not remember it, but it is nonetheless a process that's involved in explicit memory, unless that memory has been repressed. Little t trauma, we tend to dismiss it. Well, it's developmental trauma. Well, what I would say to you is this. If you're 2 years old and your mommy decides she'd rather drink than feed you, and you're starving, I would call that an existential threat. So we need to remember that little t traumas may not be the big events that scare us as adults, but as children, those little t traumas can kill us. Because if our parents don't feed us, we will starve to death. And if our parents don't protect us from the nasty German Shepherd, we will get killed by the German Shepherd. And if we're cold, we'll freeze to death, right? So, and letting you know that all of those little t traumas that I just listed activate the sympathetic nervous system. The baby starts to cry. The crying gets mom's attention. The mommy comes over and says, are you cold? Are you hungry? Whatever it is, right? But the point is that it activates the sympathetic nervous system of the baby. So the baby is in an activated sympathetic state until it is soothed by the mother. So these little t traumas are actually big T traumas because the child has no recourse. And in that context, think of it this way. If you're 13 and you're being sexually abused by your stepfather and your mother's too drunk to care or calls you a liar, Personally, I think alcohol and marijuana are really good solutions to the problem. We need to stop thinking of drugs and alcohol as problems and start thinking of them as solutions. Because if we can recognize what the solution is, we can start working backwards and look at what the problem is. We're not going to solve the problem just by examining behavior. Neither are we going to solve the problem just by throwing the right set of medications. We need to recognize that these are unconscious psychodynamic processes that have been hardwired into the brain. They can be rewired, but they are hardwired in. And if we don't heal our patients through relationship, through connection, through attachment, then we actually are just setting them up for another problem. They'll just find something else to do. Like the alcoholic who just becomes a compulsive exerciser and eating disordered, right? So this is, I know I'm out of time, so I'm going to just sort of stop here. There's like more crap in here than you could ever care about learning. But I want to end it on just this note. This is the work we do. We do the work of relationship. Our patients come into our offices and they tell us their stories. And they don't even know the story that they're telling us necessarily. They know a narrative, but they don't understand the story. It's our job to understand, to imagine what the story is. We must be able to imagine our patients. And in order to imagine them, we must understand what it means to be an infant who can't take care of themselves, what it means to be a 3-year-old who can't remember. You're 23 now, but you can't remember what happened, but you know that when somebody does this, you're terrified. We must be able to imagine the holographic puzzle of how we become human beings, because that's how we illuminate things for them. That's how we help them find their way. And the most important thing we do is to recognize that ventral vagal process of connection and attachment. In the relationship that we have with our patients, what we are actually doing is creating a new matrix of relationship that is a safe attachment experience. And that is how we heal our patients. We don't heal them because we know, drive theory or because we know antidepressants. We heal them because we're capable of showing up for them as empathetic, emotional beings who are clear enough to know these are my boundaries, that's where you stop and I start. We need to have our boundaries. But what we need to do is have relationship, because that is the sacred space of working in the mental health field, of being a therapist and even a psychiatrist. It is our job to create that sacred connection that is what ultimately heals us. So you guys, thank you. There's a lot more slides if you want copies. Thank you.